All of us know about the histological classification of the gastric cancer by WHO, Japanese Gastric Cancer Association, and Lawrence classification, and also AJCC TNM classification. And the stage-wise survival decreases as the progression of the stage. So why there is a need for new classification in spite of all these classifications? Because the current systems of classifications, they are insufficient guide to the personalized treatment of the gastric cancer. The recurrent rates remain high in the latter stage of the gastric cancer to the tune of 25 to 40%. And gastric cancer is a heterogeneous and multifactorial disease, which is influenced by both environmental and genetic risk factors. So the current treatment, like one size fit for all approach, which is not suitable for all varieties of gastric cancer. And there is insufficient attention on the underlying molecular mechanisms. So with study of gastric cancer at molecular level, we can have a tailored treatment approaches, we can improve the response rates, we can reduce the adverse effects of chemotherapy, unwanted chemotherapy, and we can plan targeted therapy, and we can have a better prognostication of the disease. So this is molecular mechanisms and signaling, various molecular mechanisms and signaling pathways in gastric cancer, the arrow marks where we target our target therapy. So these are the different molecular classifications of the gastric cancer. The widely accepted classifications are TCGA and ACRG classification, that is the Cancer Genome Atlas classification and Asian Cancer Research Group of classification. The other classifications, they are divided into 4 subtypes, and other classifications are protein and mRNA expression-based classification. The classification described by Bingley Group from China, and Onslade molecular classification, and Singapore Duke classification. So the Cancer Genome Atlas classification, these are 4 major subtypes. The first one is Epstein-Barr virus associated classification. Associated histology here is lymphoid stroma, predominantly located in the cardia to body. And the chromosomal copy number changes here are very rare. The mutations are PIK3 mutations and ARID1A mutations and PDL1 and L2 mutations, and it is in comparison with the ACRG classification, the MSS P53 negative variety. The second one is microsatellite instability variety. Here the histology is variable, both intraepithelial and stromal lymphocytes are there. Predominantly they are located in the body to antrum. Here also chromosomal copy number variations are rare. The associated mutations are receptor tyrosine kinase and PIK3CA mutations, and it corresponds to MSI variety of the ACRG classification. The third one is genomically stable variety. Here the histology is diffuse type, predominantly located in the antrum. The major mutations here are CDH1 and RHYA mutations, and it corresponds to MSS EMT variety of the ACRG classification. The fourth one is chromosomal instability variety. Here the histology is intestinal type, predominantly located in the G junction and cardia. But here the chromosomal copy number changes are frequent here, and associated mutations are P53 and tyrosine kinase mutations. It correlates with the MSS P53 negative variety of the ACRG classification. The ACRG classification again divided into 4 subtypes. The MSI, the tumors predominantly located in the antral region with the associated intestinal type of histology. They diagnose at early age, and they have associated with hypermutation, and they have a best prognosis, and it corresponds to MSI variety of the TCGA classification. And microsatellite stable with epithelial mesenchymal transition variety of the second one, which is usually seen in younger patient, predominantly in the body part. They have diffuse type of histology. They have loss of CDH1 expression, and they have worse prognosis, overlap with the genomically stable variety of the TCGA classification. The third one is microsatellite stable with TP53 positive variety. They have active TP53 positive pathway, and they are usually associated with the Epstein-Barr virus infection. They have intermediate prognosis. It overlap with the ABV variety of the TCGA classification. The fourth one is MSS TP53 negative. They have TP53 inactive pathway, and they have intermediate prognosis, overlap with the chromosomal instability variety of the TCGA classification. The other one is protein and mRNA expressed based classification, divided into EBV tumors, MSI, EMT, aberrant TP53 expression tumors, and normal TP53 expression tumors. So usually the EBV tumors, they have a good prognosis. They are usually seen in males and body location. They are comparable to EBV variety of the TCGA. The MSI tumors, they also have a good prognosis, mostly well and moderately differentiated type. better prognosis, usually seen in old age with distal location, lower in category, so corresponds to MSA variety of the both other classifications. EMT tumors, they are diffuse type, they have worst prognosis, usually seen in young age, higher T and N category, corresponds to genomically stable variety of the TCGA and MSS-CMT variety of the ACRG classification. The fourth one is aberrant P53 expression tumors. They have intestinal type of histology, they have intermediate prognosis, higher in category, correlate with the CIN variety of the TCGA classification and MSS-TP53 negative variety of the ACRG classification. The final one is normal P53 expression tumors. So they have intermediate prognosis. Comparison with the ACRG classification, MSS-TP53 positive variety.